very basic, and one in the lower jaw that we will see later, which is a more bit complicated. The case in the upper jaw has two gingival recessions at the level of the canine and first premolar of about 2 millimeters each in depth, with good residual amount of keratinized tissue, even if this keratinized tissue, obviously it's not enormous, but also the gingival recession, it's quite shallow. So there's no indication for the use of connective tissue graft. So I want to show you the surgical technique for treatment of gingival recessions, but with vertical releasing incision that, different from what I explained to you yesterday, there will be triangular shape in order to see which is the advantage of the triangular shape incision with respect to the trapezial. Even if I already told you yesterday, you should always start with the trapezial because are less dangerous, and you can also make some small mistake, and this is not such a big problem. In this situation in which we have good enough keratinized tissue, but the thickness of this keratinized tissue is really poor, there is the indication to add to the coronally advanced flap the use of a mucograft. The mucograft, as we will see, is a substitute of its matrix made of collagen that is used to improve stability of the blood clot and in such a way improve the healing of the clot under the flap and increase the soft tissue thickness. So the indication to the use of mucograft with respect to the connective tissue graft is that when you only need increase in the soft tissue thickness, but you don't have any problem relating the use of the presence of keratinized tissue. Now we make anesthesia. I turn the needle towards the area to be treated, and since the tooth that has to be treated are the lateral, are the canine and the premolar, se facessimo anche il laterale, poverino, c'ha un pochino. I make anesthesia at the level of the central. I turn the needle towards the area. Oh. Without making any perforation. Because if you look at very, very close, fai una close view sul lateral, there is a small... Al laterale?
C'è la siringa perché non si vede tutto. Ma si
Ah
vede
no, parlo della recessione io.
Sì, sì, va bene.
There is a small gingival recession also in the lateral. And the fact that also the lateral will be included in the flap design permit me to show you the technique for treatment of multiple gingival recessions with no vertical releasing incision. So I can explain it to you and make. So we will make treatment from 2 to 4, while the 5 and 6 are perfectly healthy. Again, I make anesthesia at the level of the 5, which will not included in the flap design. Bisogna che venga a fare la pulizia. Quando è che viene? We wait for the anesthesia to spread in the whole area. But you see, the pedicle, namely the most apical extension of our flap, is completely free from perforation, because I really believe that the best vascular supply comes from the pedicle. So I will never make surgery in which there is apical incision. And if I have to make anesthesia at the level of the canine, I will make very, very high. You see, in the alveolar mucosa belonging to the lip, which is not an area that will be included in that portion of the flap covering the root. I never make anesthesia at the level of the papilla, because the papilla are the vascular bed onto which I give stability to my coronary advanced flap, and I never make anesthesia in the area of the pedicle. Vogliamo lasciare proprio quella zona sanguinante che sembra che stia morendo di sanguata? Un po' più giù il mento, così. When we are treating multiple gingival recessions, all incisions must be directed towards the midline passing through the mid-buccal surface of the canine. Namely, we will start from the gingival recession and make oblique incision direct towards the canine for the teeth with gingival recessions. We have to start at the level of the canine, 2 millimeters gingival recession. We have to add 1 millimeter, namely 3 millimeters, and we have to predetermine a point that will be followed by our knife in our incision. The same 3 millimeters, 2 millimeters plus 1 will be reported from the premolar to the canine. Then we measure the very small 1 millimeter gingival recession of the lateral. We add 1 millimeter and we make another oblique incision from the central to the lateral. Since the 5 is completely healthy, instead of extending a flap to a tooth that is completely healthy, we will make an oblique incision, vertical releasing incision, that is exactly the same shape of the other oblique incision. Voglio la micro? La beaver. Of the other incision, in order to make the flap absolutely the same in the area of the oblique incision and in the area of the vertical releasing incision. This is called multiple gingival recession with one vertical releasing incision distal to the last tooth with gingival recession. Ma dove che? Design means that I will start from the lateral and I will get the canine, making a bleeding line. I will start from the premolar and I will get to the canine. I will start from the central and I will get to the lateral, while I will make only one vertical releasing incision, oblique, distal to the premolar, which create a triangular shaped papilla distal to the second premolar that has exactly the same shape of the anatomic papilla comprised between the two premolars. Now that the flap design has been made, I get in my incision line. I have to keep the integrity of the tip of this papilla by preserving an epithelium connective tissue layer. Once the tip is conchoir, this is the conchoir of the tip. We have only one tip in triangular shaped papilla. Is it possible to use my knife parallel to the soft tissue and complete papilla elevation split thickness? Papilla elevation split thickness ends in the probable area of the first premolar. So when we are open this papilla, we are opening also the sulcus of both premolars. Right? Now we are doing the same thing on this surgical papilla. We design the tip of it. Come è stata fatta male la preparazione iniziale, ragazzi miei. We want to keep the integrity of the tip of this papilla also. And once this angle have been elevated, we can go parallel until sulcus area of the canine. So now another surgical papilla. 1, 2 surgical papilla have been elevated. Now I'm going to prepare another triangular shape. Very careful in giving a good thickness epithelium and connective tissue thickness to the tip of the triangular shaped papilla. And again, I want to reach the base of this papilla, and now it's possible to elevate it like this. Like this. Now I have to prepare the surgical papilla of the vertical releasing incision, so I make this incision deeper. I take the tip, trying to give the right triangular shape. And once the tip can be elevated, trying to maintain a good thickness, even if it's very thin, much more difficult. Now the tip is elevated, it's possible to go with a knife parallel to the soft tissue and complete the last
Ruota un pochino di verso qua, brandissimo. No, la testa per giocare.
split thickness papilla. Via.
Riesce ad andare da sotto, se no sotto tutto il lembo, no, così è meglio. Se riesco a respirare è meglio così.
Okay, now we reach the base, and so also this split thickness papilla with connective tissue and epithelium in the tip is elevated. Now we take the periosteum elevator and we start with the full thickness flap elevation at the teeth with the greater amount of keratinized tissue, reaching the bone crest and go 3 millimeters beyond. The same is done at the level of the premolar, reaching the bone crest, and once the bone crest is reached, I can go 3 millimeters beyond. Now we change the periosteum elevator because I need a larger one for the canine. We make a full thickness flap elevation also at the level of the canine in order to expose the bone crest and 3 millimeters of bone apical to the bone crest, and also a slight full thickness flap elevation is made at the level of the central in order to be able to complete coverage of the lateral. So now full thickness flap elevation in order to expose the bone has been made in all treated gingival recession. Now, in order to make my flap corneal advance, I have to get rid from muscles, but muscles you see along this line is inserting in the bone, or better in the periosteum. So, voglio la 15C? No, C. So I will make a deep incision, tieni qua. First of all, I will use the vertical releasing incision, which has already been designed with a very split thickness incision in order to avoid any scar formation. And then I continue this incision by keeping the blade parallel to the bone. This is a very difficult area. You see the keratinized tissue and the alveolar mucosa are very, very close to the bone, so I prefer to overlap this area with a full thickness flap elevation, because the risk of perforation in this area is very high. And I will show you by using this method what is this deep incision means, that the muscles of the alveolar mucosa have been to detach from the periosteum. You see that now they have been detached. Again here, muscle attached to the bone, now parallel to the bone, parallel to the bone, and only the periosteum is left above the bone. And once this deep incision has been performed, sonda, I can use the probe to go parallel to the lining mucosa. You see how thin is the lining mucosa exactly in this area where it was almost attached to the periosteum. It's very, 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 very risky, this area, because the lining mucosa it's very, very close to the periosteum. So now it's possible to change the inclination, and instead of being parallel to the bone, I start to be parallel to the lining mucosa, and I'm using my blade to detach all muscles. Here there is still to remove the muscle from the bone, and now I can make my blade parallel to the lining mucosa, and this is how it is done. There shouldn't be any interruption in the movement of my blade below the tissue. And this is more than enough to corneally advance the flap at the level of the canine and at the level of the premolar. Now I have to make some deep and superficial incision also at the level of the central incisor. This is the deep, and this is the superficial one, which is use the blade parallel to the soft tissue, so that this papilla will rotate and cover also the lateral. This papilla will rotate towards the periphery and covers also the canine. This papilla will rotate distal and covers both the canine and the premolar. And now we will see that during the rotation of this surgical papilla that is going to cover also the premolar, there is some overlapping from the flap to the adjacent soft tissue that will be used to improve the vascular bed distal. But now this is the time where there is much more bleeding, so we take a gauze and start the compression with the fingers in the apical direction in order to expose the root and start with the root planing procedure. Mamma mia, brutte che sono. This is the new type of curette that I was asked to try, but they are not really like something I like to try because it's too big. If you use curette like this, you see this is a Gracie, how big it is. The risk is to flat too much the surface, while I'm using this kind of curette, which is exactly 1/3 of the original one. And the last millimeter
Poco proprio il dito, quello lì che fa un po' prima l'ombra. Quello, il medio, il centrale. Ecco, bravissimo.
the last millimeter of the root exposure close to the bone, it is not grinded because it was not probable before the surgery, and we still have some healthy root cementum with connective tissue fibers still inserted. Once half of the root is now hard and smooth, we turn the extremity of the curette and we are making root planing of the other half. Now we go to the premolar and change the gauze. You see that the bleeding is now really under control. And we start with the root planing of the premolar area. Change the extremity of the curette to make root planing of the distal portion. when you hear the difference in the noise of the dentin that is going to be planned, it means that the root is ready. Okay, now we go to the lateral, which is the last tooth to be treated. Change the gauze again. Isolate the root with the fingers and the gauze and make root planing. Okay, now root planing has been completed. We can see the whole area. Close? No, prima andiamo in bagno. Dai, fisiologica. You see that now bleeding is completely
Sul vestibolo.
under control despite very, very thin tissue. There is a really very clean surface onto which we are applying our ADTA gel in order to improve blood adhesion to the dentin tubuli. Now we leave the patient for 2 minutes before rinsing. Okay. Now we are rinsing a lot. For about 1 minute. Tieni il labbro qui, sì. In order to remove all remnants of ADTA at the level of the root. Okay, now I can show you, qua, pinzetta e micro. When I place the surgical papilla above the anatomic papilla, there is an area of overlapping that now I can sign. And this area that is now being signed will be a very, very long bevel, namely a desepithelialization made with the blade in order to leave only some connective tissue, but the whole epithelium has to be removed until, tieni qua, Kate, tirare largo, until we reach the tip of the papilla. Appoggiare. This area is going to be desepitalized
Tempo d'ombra. Vestibolo.
with the blade in order to create a very, very long connective tissue bed onto which we will place our vertical releasing incision forbicine in order to avoid completely any sign, right? Any sign of the vertical releasing incision. Sei davanti, dai. Mamma mia. Sì. Must be removed. So now when I'm going to place my surgical papilla above the anatomic papilla, there is no area that will heal by secondary intention, but everything will be perfectly covered by my flap. Now we do the same thing on the other papilla. Tienimi lì, il labbro. Okay, I have to use my blade parallel to the soft tissue, preparing this surface. No, via, dai, sei troppo così. And follow the line I prepare with my blade with the scissors to reach the tip of the papilla. Now we are doing the same on the other papilla. When the surface is quite clear to be followed by the microsurgical scissors, I remove the epithelial remnants and reach the tip. The final papilla is that at the level of the central incisor, following again the epithelium layer only, make it separated from the connective tissue, and this surface is followed by the microsurgical scissors so that all epithelium remnants are eliminated. Now we can see the whole area of the surgery. Both in this area it's connective tissue until the papilla, and the connective tissue is completely free from epithelium, so we will place our surgical papilla above the anatomic papilla, surgical papilla above the anatomic papilla, surgical papilla above the anatomic papilla, and in such a way all gingival recessions will be covered. But we decided that we want to improve the thickness of the situation at the level of the premolar, so we use this new material that it's a substitute which is made of collagen. It's bovine collagen. Mouth of the patient during the preparation of the mucograft. It's single packaging. And this is how the material is presented once it has been opened. We placed on our table. You see the thickness of this material?
Sono fermato.
Seems to be more smooth. Is that one facing the root? While this one that seems to be more rough is that one facing the flap. So this is the surface facing the root. Okay? We said we will take about 7 millimeter height because the gingival recession are quite small. And we set about 18 millimeter long, so more or less in this direction. So we mark the area that has to be cut.
15. Così.
Lo prendo tutto, dai. So we have to make a very sharp incision with the blade. And if there is too much material on one side, we will remove it. So we have the material very, very well preserved. We said about 18 millimeters for about 7, 8. You see that the thickness of the material is very, very important when it's dry. It's more than 3 millimeters. In this situation, it's quite difficult to be sutured. So I prefer, this is in the area that has been to suture against the teeth. So to improve the stabilization of the material at the base of the papilla, I make only in the angles some hydratation in order to be able to suturing it better. Now we take the material with us. Okay. The material seems to be very, very thick, but you will see that much of this material will be reduced in thickness after suturing it. Now, the most important thing is to stabilize this papilla, and so that's why I wet it at the base of the anatomic papilla. So I take the material, I take the connective tissue that I left at the base of the papilla by using this very, very small needle. It's almost impossible to stabilize this. So again, material,
Quella di bocca, proprio girata, tipo così, non la testa come
io non vedo niente.
Ok. Perfetto. Brava, brava.
Now we have to be very, very careful to stabilize the knot above the material in order not to place the material too much corner. Ora è praticamente impossibile riuscire a superarlo a queste papille.
Anche perché sono in mezzo con la fuori bocca. Però.
Dai, sì. Allora, sì, un attimo solo. We want the material is placed above the bone. Now we are looking for a good adaptation. I cannot do it with... Chi è che ha spento? Apra prima? Brava.
Ho la testa girata.
I have to make the second suturing of this material at the base of the second papilla. The material must be placed 1 millimeter more corner with respect to the cement enamel junction because it's not obviously a connective tissue graft, so we have no risk of exposure of the material because it's less stable. And now we start to place the material below the flap because it must becomes red due to the coagulum formation. We have to be very careful in order to give blood to this material that is a sort of sponge. Now I have to suture the last area of the material to the base of the last papilla. It's very difficult in this area because the papilla is bleeding a bit, but bleeding is something that I like with this material because obviously I need blood. I have to see better here the difference between the material and the base of the anatomic papilla. Io non so dov'è. Apre?
Respirare.
Apre bene.
Vengo via.
Tenti il dito. Lasciami, scusami, per favore. Lo vedi adesso?
Poco. Ok.
Okay, the problem with this material is its main advantages, that we cannot suction too much on it, because I want you to see how in the profile, how much is this material able to incorporate blood. Mi dai un po' di fisiologica? You see that now the material is incorporating a lot of blood, and so the thickness is very important, and this is the main use of the material to increase the blood. And now we have to wait for about 2 or 3 minutes so that the blood is forming thanks to the presence of this material before suturing it.
Curiosità. Aspetta. Stanno parlando proprio loro.
Here. To avoid as much as possible the compressive effect by the flap on the material. So now we take the papilla non me ne frega un cavolo, in position, open, and we give anchorage to the distal papilla with a sling suture that has not been included in the flap design, because this papilla between the two premolar is going to rotate it distal we come back to the starting point.
Aspetta che rado il tutto però.
Mm.
Aspetta che rado il tutto che non siamo sotto il 5.
And now I'm closing the papilla above the surgical papilla. Morbido, eh? Dai quella fisiologica. This should not be done with the lip retractor, obviously. And now I have to close that to the adjacent tissue. Again, from the flap to the adjacent soft tissue, covering completely the blood clot. But leaving as much as possible to the blood above the root so that the material can work to increase the soft tissue thickness. Now I'm going to give the suturing mesial. Look at how nice is the coagulum here, how thick it is. We have to cover it completely with our flap and put it below. Put it below. This suture, which was done before, now is going to be removed because it was done when there was too much tension, as I told you yesterday. And I will give it again now that there is already vertical releasing incision open. Okay, 6. So you can see that the papilla now is in the right position with no tension. It has to cover completely the desepithelialized. So surgical anatomic papilla. Now the papilla is right in the position, and thanks to the closure of the vertical releasing incision first, give anchorage distal, as I told you before. And make a compression exactly in the middle. Surgical anatomic papilla. I don't like too much. Right. And once the papilla is in the right position, I can close the knot. By physiologic. That the papilla between the central and the lateral is in the right position.
Un tramontino di filo vicino al termine.
Sì, adesso lo togliamo.
Perfetto.
Again, I give anchorage to the mesial papilla, which has not been elevated. Lascia morbido, eh? Morbido. Lasciami l'apriribocca, togliamelo. Dai. So that also the small gingival recession on the lateral is completely covered. Anatomic papilla.
Un po' più aperto. C'è.
Apro prima. Below the contact point. Aspetta un attimo. Again. Surgical sentirà appena anatomic papilla.
C'è.
And before closing this, I come back to the original
Adesso
point. Vieni qua. È sotto sì.
si può fare meglio.
Now I have to keep I have to pull because I have to achieve the ischemia of the keratinized tissue at the level of the canine and at the level of the premolar. So now you see that the keratinized tissue, both at the level of the premolar and the canine, is well adapted to the convexity of the clinical crown. I left this papilla with no knot so I can improve again the coronal advancement of this flap. Apra un pochino.
No, no.
Because I want to be sure that the keratinized tissue is in a more coronal position with respect to the material in order not to risk any exposure of the coagulum during the healing phase. And now I close and give good adaptation of the papilla also between the lateral and the central and improve the ischemia of the keratinized tissue around the canine. Now I will show you the picture of the area. You see the difference between the volume of the soft tissue at the level of the lateral, where no material was placed, with respect to the canine and the premolar, where there was the adjunct of the material. But in terms of marginal stability, there is no blood escaping from the soft tissue margin in any of the treated teeth. Now I want to show you the profile of this area in order to better understand what I mean in terms of thickness. Both the canine and the premolar, there is a big increase in blood clot below that it will be organized in new connective tissue, while the lateral, since the recession was extremely small and there was a good quality of the keratinized tissue, it was not necessary to add the material. Okay, if you pull the lip, there is stability of the soft tissue margin and the blood clot is going to be stabilized above the root. Okay.